Hello, I'm Peter Mogayzel, and I'm here with Professor John Moore from the Department of Clinical Microbiology at Belfast City Hospital, which serves the Northern Ireland Cystic Fibrosis Center. We're at the European Cystic Fibrosis Society meeting in Hamburg, Germany. Welcome, Professor Moore.
Thank you.
I wanted to get your view of risk factors that are involved in acquisition of organisms in the CF lung.
Well, there are multiple factors which are important for the acquisition of new bacteria, and they can be divided into two schools. Firstly, there are host factors, and there are organism factors. I think immediately everyone from the host factor point of view, this is really the discussion of good infection control. And, with regard to if we get it right, we hopefully will limit the transmission of organisms between patients. And if we get it wrong, then that will fuel the potential for cross-infection. And we need to be very due diligent in terms of the healthcare environment, that we get it right as healthcare professionals to have a good evidence-based biology to know how these organisms transmit and how to put effective interventions in to limit their transmission between patient and the environment, or the environment and patient, or patient to patient. And we all know the very well trodden and very well populated area of literature with regard to good infection control measures. There are other factors such as CF mutation. For example, we know that CFTR can be there can be a trophism for Pseudomonas aeruginosa to CFTR or defective CFTR protein, in terms of the CFTR acting actually as a receptor for Pseudomonas. But with other CF mutations, in terms of the mutation types 1 to 3, where we're seeing minimal CFTR function, versus types 4 and 5, where we're seeing maybe some residual type in the less severe mutations within cystic fibrosis, then we see a different type of microbial ecology develop. Where with those atypical or rare forms, generally the progression of lung disease isn't as marked, and where maybe people have got more of a focus on liver disease or on gastrointestinal disease or infertility in males. But generally these people with these type of residual activities will have not as much lung morbidity as patients with delta F508.
Okay.
And we see that manifest in clinics where we see patients with unusual CF genotypes having strange microbiology, which really isn't, I don't think, too clinically significant, where they've got, instead of having Pseudomonas aeruginosa, they've got organisms like E. coli, Enterobacter, Bovundomonas, and transient Pseudomonas other than Pseudomonas aeruginosa, so the likes of Pseudomonas putida and Pseudomonas fluorescens. But these organisms are hopping in and out, probably as passengers of their CF airways, as opposed to being pathogens.
Sure.
So what we have to think about how these bacteria survive the environment. At the end of the day, all they want to do is they just want to be able to survive and proliferate either in the environment or in the host or wherever they find themselves colonizing.
We often think of the CF lung or infections in the CF lung in terms of Pseudomonas and Staph aureus. Do you think we're taking too narrow a view of infection?
I think it was narrow, but it was well intentioned with the tools that we had at the time to look at a microbial flora within the airways secretions and sputum or upper nasal secretions. I think with the advent of developing new molecular techniques, the analogy is we can either look at the lung in terms of using Granny's reading glasses, or we can use the radio telescope of Jodrell Bank in Cheshire in England. And what we find is completely different scenarios. If we use Granny's reading glasses, then all we will see will be the likes of Pseudomonas and Staph aureus and the things that are obvious to us. Sometimes even with those methodologies, we see people who've got exacerbations, and we're having great trouble even using those methodologies, trying to dig some organisms that make sense to correlate with the patient's acute exacerbation. Having said that, we've got new technologies, and there are a couple of people advocates of that. There's Susan Lynch from UCSF and Ken Bruce from London, who are now using these molecular modalities. And as we use these molecular modalities, these methods have got very high discriminatory power. So what we're doing is we're really sort of doing a deep look at what's in the CF airways, not just at those organisms which are culturable, because for the last 100 years, clinical microbiology has been had its surrogate of being able to culture it. in a routine fashion, we haven't really moved on very far from the pioneers of microbiology, namely Louis Pasteur and Robert Koch. Mm-hmm. And we're still using these culture-dependent methodologies to gain the answers. That's reasonably secure because most of the organisms that cause infection in medical diseases grow relatively easily in the laboratory. But when you think about it conceptually, what we're trying to do is we're trying to mimic the in vivo situation in the laboratory by creating a series of artificial events in terms of culture media, time, which sometimes is totally alien to how these organisms grow in the laboratory. And for some reasons, some of these organisms won't grow. For example, they obligate intracellular pathogens such as Coxiella, which causes Q fever, or some of the rickettsia, or even Mycobacterium leprae, which is the causal organism of leprosy. We simply can't grow these organisms, or another organism such as Whipple's bacillus or Trifluema whippelii, where it's just simply impossible to grow them in the laboratory. So I think we're going to see a movement away from the routine methodologies for clinical microbiology and the introduction of a limited introduction of some of these molecular assays to help actually determine the organisms if they go into this viable but non-culturable form, because otherwise we're really sort of looking for the invisible man.
There are a number of new inhaled antibiotics that are on the horizon. How do you think that will affect therapy looking to the future?
Well, I think the good news here is that inhalational antibiotics for the treatment of Pseudomonas has been a great success story over the years. It's probably one of the factors which has seen an improvement in both mortality and morbidity in our patients with cystic fibrosis. But as Newton once said, for every action there is an opposite and equal reaction. We all are very conversant with the action, namely the reduction in morbidity and mortality from inhalational antibiotics. But now we're beginning to tease out what the equal and opposite reaction is. And that's certainly coming back, that's certainly the idea of displacement and alteration of the microbiome or the ecology of the bacteria living in the lungs. So I think what we will have to do in the future will be to see in terms of with the number of antibiotics we've got available on the inhalational route. And the good news is that we've got 4 different classes of antibiotic, which makes the potential efficacy of those agents more effective. We've got a fluoroquinolone, we've got a beta-lactam, we've got a polymyxin, and we've got an aminoglycoside. That's good news, because if we had 4 agents of the same class, then the potential efficacy would be a lot more limited. The problem comes in terms of what is the best way that we cycle these antibiotics, because we've got certain 28 days on, 28 days off. With 4 drugs, and when you do the mathematics, we've got 24 combinations of not repeating that. And it's very, very difficult to decide, do we go aminoglycoside, beta-lactam, fluoroquinolone, and whatever order we go. And I think we're going to have to think very carefully and have a good evidence base for deciding how is the cycling going to work best. How that's going to work best, it depends what question you ask. Firstly, are we interested in clinical outcomes, or are we interested in antibiotic resistance? I think probably like all things, the truth will lie somewhere in the middle. And we have to strive towards getting some sort of an evidence-based model for stewardship to be able to keep the efficacy going as long as we can with these antibiotics. We're not developing antibiotics. In the last 2 decades, we've probably only seen 2 classes of new antibiotic. We've seen the oxalidones from the Nasalid from Pfizer, and we've seen daptomycin for MRSA and glycopeptide-resistant staphylococcal right-sided endocarditis being developed by Novartis. So because of that we have to, I think, use our antibiotics more judiciously. And I think this will maybe light the fire with CF physicians and being able to have a structured and quantitative way of how we prescribe our antibiotics for those 2 outcomes.
Well, thank you very much, Dr. Moore, for taking the time to talk with me today about infection in the CF lung.
Thank you.